So we all have a subjective sense of what health and illness mean. We think of ourselves as healthy, as being free from disease, whereas illness is the presence of sickness or disease. But how healthy do you have to be able to optimally function? Can you remain healthy despite everyday aches and pains? So we have to ask ourselves, what do people mean by this concept of health and illness? Anthropologists apply their real world knowledge, their knowledge of culture, biology, and disease to these real world health crises. And there is a relative cultural context of sick role, which is a culturally defined agreement between patients and family members to be able to acknowledge when someone is legitimately sick. We've got other individuals, though, aside from anthropologists, working to maintain health, right? We've got our entire healthcare field, which we think of as doctors, nurses, epidemiologists, public health officials, etc., employing typically Western means to heal people, medications, maybe psychotherapy, vaccination, etc. Um, Medical anthropologists differ from these healthcare workers, specifically in how they emphasize illness and disease as culturally influenced subjective states. So they recognize that individuals, even if they have underlying infections, may not consider themselves ill. The Tsimane, for example, with underlying parasite infections, as long as they're still able to function, they just get by with it. That's just part of the norm for them. And so we see that if we ask people whether they consider themselves healthy or ill, this acknowledgement of illness is incredibly variable. People without adequate health care in the US can't afford to be sick, right? Um, and so Earl Coos in the 1940s studied American illness and showed the following. One respondent described sometimes feeling so bad that she could curl up and die, but wasn't sick. She couldn't be sick because her family lacked the money to visit a doctor and her kids still needed care. Low income, low socioeconomic status individuals can't afford to be sick even when they need to be. Um, Other people who have sufficient wealth to be sick often can seek medical treatment for even minor ailments. I am typically someone who, I mean, I don't avoid doctors, but we don't go to doctors for things like a runny nose and a sore throat, or if we happen to be running a fever. I tend to take that wait and see approach, and give it a few days, give it a week, with over-the-counter medication sometimes, with herbal treatments, etc., to see how we end up feeling, see whether it develops into something serious enough that we need to go to a doctor. And I mean, most of the quote-unquote illnesses that my family experiences, whether it's us adults or whether it's the kids, are minor and don't really require um, visiting a doctor, accessing healthcare. Think of how different your kind of attack or even definitions of being sick would be if we had single payer universal healthcare, right? Would you have problems that you might actually get addressed given not having to pay for private health insurance? I would probably be more proactive in my treatment of my migraines. I tend to work through my migraines because I've got usually one or two a week, and you can't stop being a mom. You can't call in sick for work that often with chronic migraines. In parts of Mali, there are infection rates of schistosomiasis. That is a parasite that you get from, and it's basically a parasitic worm, that are so high that it's not even locally recognized as an illness. One of the symptoms that they have from schistosomiasis um, so schistosomiasis is a liver and bladder infection by this parasitic worm. So one of the symptoms is blood in the urine. This is experienced so frequently by adolescent males that they associate it with part of their pubertal transition, rather than it being associated with parasites. It's so normal. Everybody has blood in their urine as they turn from a young boy into an adolescent. People rarely worry about the symptoms that are common in their environment. I mean, if we saw blood in our urine, we would probably hurry to the doctor because it's not something that we are burdened with every day. So this sick role ties into social expectations, and these social expectations are related to illness and vary with class, gender, age, employment, and lifestyle. People in poverty usually work more physically demanding jobs. They eat less healthy food. They're less likely to seek medical care, right? People in poverty may not be able to keep their kids home when their kids are sick. This is a worry. This has been a worry with coronavirus. This is a worry about whether schools reopen under normal classroom conditions. As teachers, we know that parents often send their kids to school sick. I have sent my kids to school sick, not with some major illness, but if they're not running a fever and they have a cough and a runny nose, right? I don't rush to keep them at home. In this age of coronavirus, though, we have to worry about those little symptoms like that, right? We're having to institute basically health questionnaires that rely on people to tell the truth about it, to tell the truth about how they're feeling, tell the truth about their ailments, etc., tell the truth about their symptoms. And many people can't afford to tell the truth about it. Many people can't afford to stay home from work or school sick. So we have a natural behavior. If we are sick, we stay home and in bed. We might have chicken soup. Chicken soup has actually been demonstrated to have an effect on health and wellness. Some of it may be related to kind of what we would imagine like herbal treatments. Some of the herbs and spices that go into chicken soup, for example, we know that garlic is antimicrobial. So having diets that are high in garlic can help to kill off pathogenic bacteria. Warmth can break up mucus, so drinking warm broth can help to loosen up chest congestion and help get that thicker mucus out of your body. But some of it's also placebo effect, right? If we believe something works, we're going to have favorable results from it. And our belief of things ties in very closely to immunity, in that the placebo effect is very, very real. And people find relief from treatments that they believe will work, whether that treatment is aspirin, whether that treatment is chicken soup made by their grandma, or whether that treatment is prayer, right? Really, when it comes down to it. When you believe something works, it has a cascade effect on your internal physiology that serves to strengthen your immune response. And so, therefore, it works. Anthropologist Robert Welsh contracted malaria while conducting fieldwork among the Ninjirum people of Papua New Guinea. He then followed the American norm of medicine, fluid, seclusion, and rest. Interestingly, the villagers that he worked with had a very different perception of the sick role. They believe that illness is caused by sorcery. So they were really, really concerned with Welsh trying to isolate himself. They wanted to spend long hours with him to remove any suspicion that they themselves were involved in the sorcery, so that he wouldn't think they were the sorceress agent that caused his infection. The Ninjirum are expected to demonstrate the severity of symptoms as a call to action. So their very kind of way of attacking illness is to sympathize, to spend time with, to uplift, to engage in behavioral practices that they believe can remove those sorcerous elements. So when Ninjirum are sick, they enhance kind of their expression of symptoms. They might exaggerate their fainting, their bleeding, their vomiting, their shrieking. They would smear themselves with mud in a fit of madness. as a way to demonstrate that they've been attacked by sorcery. And they accordingly act very sympathetically to symptoms. If we were to see someone out in the streets lamenting, falling down, shrieking, smearing oneself with mud, talking about how sick they were, we'd probably call for a psych consult, right? We wouldn't have that same sort of sympathy. I mean, being a parent, I can tell you, actually, just being in a long time relationship, right? Let's build on stereotypes for a second. What is the stereotype of um, middle aged white men when they get sick, right? Um, we see and we accept different levels of complaining about symptoms from different people. I expect for kids under the age of 5 to talk about how horrible they feel, but I expect for someone at the age of 50 um, to be able to, I mean, certainly acknowledge that they're sick, but get by without so much complaining about their symptoms, right? So we can see, even in our own culture, the varying context specific cultural reactions to this quote unquote sick role. All right, so for our second, thinking critically about the body, this sick role concept works well for acute diseases like measles, bad colds, chickenpox, when we're expected as patients to want to get better and to help their own care by following medical advice. To meet these expectations, patients are often considered exempt from participating in ordinary social activities, and they're not blamed for causing their own sickness. Compare that to a chronic condition like diabetes, shortness of breath, or severe arthritis, right? Particularly diabetes and shortness of breath. Think about fat phobia in the United States. I'm fat. I will be the first to admit it. I also do CrossFit 3 to 4 days a week, and eat generally a whole foods diet, not Whole Foods the store, but like not very many carbs, not much dairy, very little sugar, mostly fruits and vegetables and lean cuts of meat and stuff. Um, so, that fat phobia constantly kind of gets thrown in my face about things. People don't believe that I actually eat healthy and work out on a regular basis. People don't believe that I may have illness that's not simply related to being fat. I mean, I once walked around on a stress fracture for 5 months before it was diagnosed because the assumption was that my foot hurt because I was fat, and if I just lost weight, I would find relief. So, some of these other problems that people face chronically that may even be environmentally caused, right? That may be or have been triggered by um, their inadequate diet or something. Think about the association of poverty with food deserts, right? People who are living in inner city areas that are characterized with high rates of poverty oftentimes are not able to have access to fresh fruits and vegetables. So they eat ramen and Cheetos and Dr. Pepper. And that's because it's all they have access to. So, do we blame them for their comorbid conditions that may contribute to um, chronic effects, chronic illnesses, right? Is it their fault? Is it easy for them to change their behavior and thusly find relief, etc.? Right? We blame obesity for so many things. And yes, absolutely, obesity is a big deal. It's a problem when we've got children under the age of 4 showing signs of type 2 diabetes. But we have to look at some of the culturally specific factors that contribute to that. It's not because parents are disregarding all medical advice and just feeding their kids cake and ice cream and soda pop, right? It's not that simple. And our inability to see people as anything but obese, I mean, this is prevalent throughout um, standard medical treatment. The first thing they notice is your weight, and the first thing they comment on is your weight, and they believe that everything is tied to your weight, and if you only lost weight, you would feel better. So, sorry, there's my little rant. Just based on some of the discrimination that I've received in standard medical care for ailments that have nothing to do with the fact that I'm fat.